Good day, everyone. I'm Dr. Christopher Alipia, and welcome to our session on addiction medicine. This lecture introduces the science of substance use disorders, how drugs act on the brain, how dependence develops, and how we diagnose and manage these conditions from a biopsychosocial perspective. Our focus will be on understanding addiction as a brain disease with psychological and social dimensions. We'll first discuss the neurobiology, particularly the reward system, then the diagnostic framework using DSM-5 and ICD, and finally, selected prototypes, alcohol as a depressant or downer, and methamphetamine or shabu as a stimulant or upper. For reference, you are required to read the DSM-5 and Kaplan and Sadok's Synopsis of Psychiatry chapters on substance-related and addictive disorders. The reward system is a network of brain structures that link pleasure, motivation, and learning. Its purpose is to reinforce behaviors that ensure survival: eating, bonding, reproduction. Drugs hijack this system by creating an artificial surge of dopamine, teaching the brain that the drug use is more important than natural rewards. So let's rewind. There are three important neurotransmitters we have to remember in addiction medicine. These are dopamine, glutamate, and GABA, or gamma aminobutyric acid. Dopamine's natural role is not simply just pleasure. It is more about salience, motivation, and learning. Salience means how our brain assigns importance to something. The brain uses dopamine to signal, hey, pay attention, this matters. Whether positive, meaning the stimuli can give a reward or potential reward, or negative, as in a threat to physical or mental integrity. It also reinforces behavior that helps survival, like eating, sex, social interaction. Dopamine in the brain is produced mainly in two areas, the VTA and the substantia nigra. The VTA, or ventral tegmental area, is relevant in our discussion of addiction medicine. As a review, their dopamine is produced from tyrosine by action of tyrosine hydroxylase forming L-DOPA, and then acted upon by dopa decarboxylase to produce dopamine. Dopamine neuron firing is mediated through tonic firing, which is related to baseline motivation or drive, and a phasic burst related to learning about unexpected rewards or cues termed as prediction error. Dopamine is dysregulated in addiction either directly through exogenous dopamine or indirectly through substances affecting the feedback loops regulating the levels of endogenous dopamine, leading to aberrant salience. There are four dopaminergic tracts in the brain, and their major roles are the following. The mesolimbic pathway is involved in reward and motivation. The mesocortical pathway is involved in decision making and impulse control. The nigrostriatal pathway is involved in habitual learning and motivation. And the tuberoinfundibular pathway is involved in prolactin production. The mesolimbic and mesocortical pathways are the pathways that are in direct connection to substance use disorders, and coincidentally in psychotic disorders. You'll notice that using too much stimulants can directly affect dopamine receptors, which can cause psychotic symptoms. Glutamate is the main excitatory neurotransmitter in the brain. It mediates learning, memory, plasticity, and it is necessary for synaptic strengthening or long-term potentiation. Glutamate in the brain is produced by glutamine released by glial cells converted by neurons. In some cases, glutamate can also be synthesized from Krebs cycle intermediates such as alpha-ketoglutarate. Glutamate binds to its receptors, the NMDA AMPA kainate metabotropic receptors, and function to encode cue-reward associations and strengthens pathways that connect a stimulus to a behavior. So in addiction, drugs use Drug use leads to glutamate projections from the prefrontal cortex or amygdala to the nucleus accumbens to become hyperpotentiated, triggering craving and relapse. I'll explain this further later on. GABA, on the other hand, is the main inhibitory neurotransmitter, or the brake system of the brain. It keeps excitatory activity in check, preventing seizures and runaway firing. It balances dopamine and glutamate to maintain homeostasis. GABA acts on via GABA A receptors, which are the fast ionotropic receptors, and the GABA B receptors, the slow metabotropic receptors. In the ventral tegmental area, GABA interneurons normally inhibit dopamine neurons. Drugs like opioids, alcohol, benzodiazepines, or cannabis, often they are called downers, often inhibit the inhibitor. So the net effect of inhibiting the inhibitor is the disinhibition of dopamine or increase in dopamine. It's like removing the brakes. Okay? So this reviews and integrates the summary of the actions of the three neurotransmitters in drugs, okay, and drug abuse. So let's discuss the core reward pathway. Observe this image showing the core of the reward pathway. The ventral tegmental area shown on the image on the left side and the nucleus accumbens on the right. The image also shows a summary of where common substances of abuse act on the reward pathway. So for example, your stimulants act on the terminus of your VTA actions by blocking the reuptake transporters of dopamine. So blocking the reuptake transporters increases the levels of your dopamine in the synaptic cleft. I have provided a summary table for you at the end of the slides, giving the mechanism of action for each drug of abuse. So now let's go into a bit more detail about the first area we described, the ventral tegmental area. Okay, we will focus on that. The VTA, or ventral tegmental area, is called an area in the rostral part of the midbrain at the level of the superior colliculi, shown here on the left. Okay? Remember that your midbrain is divided into your rostral and caudal segments, okay, towards the head and towards the tail. It's an area rather than a nucleus. It's called an area because the neurons cannot be distinguished from the dopaminergic neurons of the substantia nigra and can only be distinguished by the limbic-related afferents that project to it. Okay? There's no distinct border, unlike nuclei, so it's called an area. The dopaminergic neurons originating from this ventral tegmental area project to the nucleus accumbens, the second part of our core reward pathway. It is called the tegmentum, or meaning the floor, okay, because developmentally it formed from the floor of the neural tube as opposed to the tectum or ceiling of the midbrain. Okay? While the VTA is known for its dopaminergic neurons, it also contains GABAergic, which is inhibitory, and glutamatergic, of course, excitatory neurons that contribute to its complex functions. The VTA projects to several brain areas, and we'll study this later, including the nucleus accumbens, but that's our focus, the VTA projection to the nucleus accumbens. It also projects to the prefrontal cortex, the hippocampus, the amygdala, forming a network that regulates the reward, motivation, and emotion. So the second part of our core reward pathway is the nucleus accumbens. It is part of the ventral striatum, which in turn is part of the basal ganglia. The basal ganglia consists of the striatum, the pallidum, the subthalamic nucleus of Lewy, and the substantia nigra. Okay? The striatum, on the other hand, is composed of the ventral and the dorsal striatum. Okay? The dorsal striatum is composed of the caudate nucleus and the putamen. We will discuss the dorsal striatum later as we delve deeper in the reward pathway. However, our target here is the nucleus accumbens, which is part of your ventral striatum, along with your olfactory tubercle. The nucleus accumbens plays a role in the cognitive processing of motivation, aversion, reward, and reinforcement learning. Also shown in this image alongside the basal ganglia is the thalamus. The basal ganglia are consistently shown with the thalamus because they form a key loop in processing motor and other complex functions. While the basal ganglia receiving input from the cortex processes it and then relaying its output back to the cortex via the thalamus to refine cortical activity. This interconnected circuit is crucial for functions like voluntary movement, learning, planning, and emotional processing. Your thalamus projects to the cortex, while your basal ganglia projects to the thalamus. But while best known for its motor control, not thalamus, okay, this interconnected system also contributes to other higher cognitive functions, such as learning, emotional states, decision making, and motivation. This image shows you the evolutionary hierarchy of the development of brain areas. Notice key components of the reward system that we have discussed are pretty much more primitive than the others. So lower in this image. Okay? Your amygdala in the paleomammalian level and your VTA or your ventral tegmental area and the basal ganglia and even more older parts of the brain. The significance of this is that in the evolutionary history of human consciousness, the older parts of the brain, the older the parts of the brain, the more difficult the level of control one can exert on those brain structures. And therefore, that's why it's difficult to control addiction. Meaning, since these parts form the primitive part of the brain, relying more on instinct rather than compared to your neocortex, for example, which forms the thinking part of your brain, it is harder to overcome their influence. Most of their functions are automatic. Addiction circuits like the reward pathway or basal ganglia limbic loops are rooted in the older layers, the frontal reptilian or limbic systems. That's why conscious control from the prefrontal cortex often struggles against deep-seated drives from these areas. In addiction, there is a strong mismatch between top-down control or control from your prefrontal cortex and bottom-up drive, the influence of your nucleus accumbens, your amygdala, and your basal ganglia from the bottom. This actually explains relapse. In emotionally charged or cued contexts, older brain circuits dominate and they take over your thinking parts. So a caveat, okay? The triune brain system is a simplified metaphor to understand concepts. It is not a dogma. Modern neuroscience actually views the function of the brain as integrated networks, not separate layers fighting each other. This is a learning tool that helps us visualize why addiction feels so powerful and hard to resist, because it taps and hijacks into ancient circuits, which is hardwired for survival. Okay? So your VTA projects to your nucleus accumbens, but what projects to your VTA? Okay, hindi naman, this is not an isolated system anyway. Okay, so here are the inputs to the ventral tegmental area. First, remember that the VTA has reciprocal connectivity. Almost all brain regions that receive dopaminergic outputs from the VTA also send inputs back, okay? This makes a VTA a central hub bridging old and new brain structures. Okay, the VTA receives glutamatergic inputs, excitatory but context dependent. Its function is to drive burst firing of dopamine neurons and in effect increase dopamine release in the nucleus accumbens. This critical effect is that the critical effect of this is that drugs of abuse enhance glutamate signaling, reinforcing dopamine surges. Okay. Next, the VTA also has GABAergic inputs or inhibitory or brake inputs from the following areas, as indicated. Of note are the rostromedial tegmental area, which functions as the master brake. Okay? It strongly inhibits VTA dopamine neurons. Second, the lateral habenula, which excites our rostromedial tegmental area. GABA neurons and restromedial tegmental GABA neurons and suppresses dopamine neurons important for reward prediction error. This means that when an expected reward doesn't come, dopamine firing drops. Okay? However, certain downers can silence GABA input to your VTA, meaning it inhibits the inhibitor as I've described earlier. having a net effect of more dopamine. Okay? Next, there are cholinergic inputs to the VTA. They function as modulatory reinforcers. Okay? Cholinergic inputs reinforce VTA discharge properties, helping tune reward-related signals. Nicotine acts on this input to the VTA. There are also opioid peptides that can directly act on your VTA, acting similarly to what we previously described about GABA, because they act on mu opioid receptors on GABA interneurons. So they also inhibit the inhibitor and increase dopamine output downstream. This is the mechanism of action of opiates like morphine and heroin. Okay? An important thing to remember is that addiction vulnerability is essentially an imbalance between excitatory, your glutamate and acetylcholine, versus inhibitory regulation of the VTA. Okay? Drugs of abuse often either do one of two things. First, they can enhance excitatory drive, or second, they can silence inhibitory brakes, tipping the system towards excessive dopamine release in your nucleus accumbens. Okay? I hope this simplifies understanding of the mechanism of action of substances. Okay, how about at the other end? So we discussed the VTA and the inputs to the VTA. Your VTA connects to your nucleus accumbens. How about your nucleus accumbens? Where does your nucleus accumbens project to? Okay? So relevant to our discussion in addiction medicine are two. No? I mean, five. Okay? So the nucleus accumbens acts as the behavioral or output hub of the reward pathway. Its GABAergic projections to the ventral pallidum and the VTA control both motivation to go for it and dopamine reinforcement. This feels good. Parang ganyan. Okay? Its outputs to the amygdala, hippocampus, and the cortex integrate emotion, memory, and decision making, which is why addiction affects not only pleasure, but also habit, emotion, and cognition. Okay? So far, how have you understood the core reward pathway and the drugs of abuse and how they influence the core reward pathway? Okay. So remember, each drug class enters through a different door but ends up in the same hallway, the dopamine pathway. Stimulants like meth and cocaine cause direct dopamine release. Opioids and alcohol inhibit GABA interneurons in the VTA, releasing the brake. Nicotine directly stimulates dopamine neurons through acetylcholine. The result is a dopamine flood in the nucleus accumbens, producing the powerful reinforcement we call a high. Okay? So let's complicate things a little bit more. No? So we'll discuss beyond the VTA and the nucleus accumbens. Okay? Three important areas in the brain that is related to substance addiction. Okay? So far, we've talked about the VTA, the ventral tegmental area, and the nucleus accumbens. Remember, your nucleus accumbens is part of your, what again? Your ventral striatum. Diba? Of course, it and the VTA doesn't live in isolation, and it's connected with the stabers, right? So there are three more brain areas, as I've said, that we'll discuss. They are of particular importance in our journey in understanding why individuals become addicted. These are the dorsal striatum, okay, the neighbor of the ventral striatum, the extended amygdala, and the prefrontal cortex. Okay? Remember from before, your striatum is divided into your ventral, okay, again, your nucleus accumbens, remember, and your dorsal parts, each playing a different role in addiction progression. Your ventral striatum or your nucleus accumbens play a role in early addiction stage, okay? The reward-driven, goal-directed use, because it mediates the reinforcing high of drug use and its motivational salience. Glutamate input from the amygdala or hippocampus tags drug cues and context. Your dorsal striatum, on the other hand, play a role in later addiction or habitual and compulsive use because control shifts here with repeated drug taking. Okay? Initially, the ventral striatum slash the nucleus accumbens, and then later part of addiction in habitual and compulsive use, your dorsal striatum. Action becomes less about the reward and more about ingrained routines. Okay? The stimulus and response loops. This explains why patients relapse automatically even when the drug no longer feels good. Okay? An easy way to remember would be that your ventral striatum is your pleasure gateway, while your dorsal striatum is your autopilot habit loop. Okay? The extended amygdala is not a single structure, but a macro system of interconnected basal forebrain nuclei, consisting of the central nucleus of the amygdala, the bed nucleus of the stria terminalis, and the shell of the nucleus accumbens. So functionally, it integrates stress, fear, reward, and motivation. Okay? Its normal role are to mediate responses related to stress and threat, coordinating autonomic and behavioral outputs to maintain survival, fight or flight, arousal, and vigilance, and provides feedback to the reward system. So stop chasing the reward if danger is present, dude. Okay? In early drug use, drugs are reinforcing through the nucleus accumbens. However, again, with chronic use, the extended amygdala becomes hyperactive, leading to negative emotional states, so pwedeng depression. There is a release of stress, neuropeptides, and reduced sensitivity to natural rewards. This drives the dark side of addiction. When people take drugs not really to get high anymore, but to relieve the negative affect or the negative feeling that they have from stopping the drugs. Okay? Parang yung what we call crash. Okay? Okay, so the last important part, so we've talked about what? Your dorsal striatum, your extended amygdala, the last important brain area on our list, but never the least, as it is where control should be manifesting in all of these, is the prefrontal cortex. Okay? Different prefrontal cortex subregions have specific roles. There is your orbitofrontal cortex, and it's important in valuation and decision making. Is this worth it? Parang ganun. That's the question. What happens in addiction is that the individual overvalues drug rewards and undervalues natural rewards. This explains distorted priorities. There's your dorsal lateral prefrontal cortex, which has a role in executive control, working, memory, and planning. What happens in addiction is that there is impaired top-down inhibition, making an individual less able to resist urges. Okay? There's the anterior cingulate cortex, which has a role in error monitoring and conflict resolution. This is a bad idea. What happens in addiction is that there is blunted error signaling leading to weakened learning from negative consequences. And there's your medial prefrontal cortex, which is connected to limbic regions, the amygdala and the hippocampus, making it responsible for emotional regulation. But what happens in addiction is that stress and cue reactivity overwhelm regulation, fueling relapse. Okay? So let's integrate the things that we've learned, okay? So we were talking about the areas beyond the PTA and the nucleus accumbens, right? What were they? The dorsal striatum, the extended amygdala, and the prefrontal cortex. Remember, the dorsal striatum's role is what? Forming the habit. Okay? The extended amygdala's role is related to taking drugs to relieve the bad feeling. Okay? And the prefrontal cortex's role is related to what? The loss of control from the top. So you have just understood the three stages of addiction, actually. Okay? The Volkov model. So there are three stages involved. The binge and intoxication stage, the withdrawal and negative affect stage, and the preoccupation and anticipation stage. And these are the areas that correspondingly are responsible for each of the stages. So during the binge intoxication stage, the surge of dopamine initially provides pleasure and reward. Okay? Sabi nga natin, no? That comes from your ventral striatum or your nucleus accumbens. However, later on, actions becomes less about a reward and more about ingrained routines or habits forming stimulus response loops as a function of what? The basal ganglia. Okay? Next, when a person tries to stop using the substance or stops doing the behavioral addiction, stress systems are activated and the extended amygdala becomes hyperactive, leading to negative emotional states. There is a release of stress neuropeptides. Okay? Those, again, if you remember, we were discussing earlier, the neuropeptides will again inhibit the inhibitor. So it adds to the addiction. Okay? These are the neurotransmitters involved in this stage, produced in effect by the hyperactivity of the extended amygdala. This leads to the individual to be pushed to use drugs again to relieve the negative affect or dysphoria or sadness caused by stopping the drugs. Okay? All right, last, as I've said before, the prefrontal cortex tries to control the addiction as it is part of the neocortex or thinking or decision making area of the brain. However, heightened stress reactivity from the extended amygdala overwhelms or weakens the prefrontal regulation, increasing risk of relapse, notwithstanding the long term effects of substances directly affecting executive functioning again, weakening the ability of our thinking part to lord over the more primitive parts of the brain. Okay? So this is a summary of the three stages of addiction. Okay? This shows you the shifting drivers resulting from the chronicity of using substances or being exposed to addicting behavior. Okay? So from early drug use to chronic drug use at the right. So why treatment must be long-term and why detox is not enough? Since your dorsal striatum autopilot habit boss keeps firing, the habit persists even without conscious desire, right? The prefrontal brakes are also weakened and vulnerable. So we're not just detoxing a patient. We have to retrain. We have to retrain their cortical and striatal networks. So this explains the importance of cognitive behavioral therapy, cue exposure, and contingency management. They are all aimed at strengthening our prefrontal cortex control over the striatal drives. Okay? So here are some clinical pearls. Let's just go over them. Okay? Again, remember, it's 3v1. Your thinking part trying to defeat three heavy opponents on the bottom. Okay? Control from up above and your striatal influence from the older parts of the brain on the bottom. So you can pause for now and take a break, take a breather, and then you can continue the lecture right after. Now that we understand the general mechanism, how substances of abuse hijack the reward system, let us discuss the groups of substance-related and addictive disorders in the American Psychiatric Association's Diagnostic and Statistical Manual and the World Health Organization's International Classification of Diseases. As this lecture covers the entirety of addiction medicine, a specialization itself, it would be very difficult to discuss all must-knows in one lecture. I will give one example of a typical and common downer and a typical stimulant or upper, and just provide you with study guides of must-know information about all of the other substances that you can use not only for the purpose of this course, but as you move forward to your physician licensure exam and later on in your medical career. These are the categories of behavioral disorders due to substance use in the extant iteration of the ICD-10. These categories can each have a subcategory aiding diagnosis. These are acute intoxication, harmful use, and etc. The ICD-10 also contains these diagnoses for behavioral addiction. In the latest iteration of ICD-11, gaming disorder and hazardous gaming are also included. I will discuss these in detail in the second part of this lecture, specific for behavioral addictions. The DSM-5 include these categories for substance-related and addictive disorders. It would be easier to remember this structure for almost all DSM-5 disorders, not only addictive disorders. The diagnosis will always include, first, an inclusion criteria, listing what symptoms or symptom constellations are usually seen in an individual. Second, the DSM usually assigns a temporal requirement, meaning a time frame when a symptom or symptoms are observed or occur. Third, there is usually a requirement that the symptoms are of enough severity to affect the social and occupational functioning of an individual. And last, there are usually exclusionary requirements. These are either statements that symptoms are not being caused by specific disorders, and this aids differential diagnosis. DSM diagnoses also include notes and specifiers, which while are not strictly required in giving are strictly required, they usually aid in giving characterization for the said disorders. For example, in substance use disorders, specifiers can describe whether the substance use disorder is in partial remission or in sustained remission, telling the reader that while the individual has a history of alcohol use, for example, he is presently sober and is in sustained remission, which has a required time frame for a person to satisfy that specific specifier. Okay? Each of the DSM-5 related and addictive disorders can be combined with this diagnosis, with the exception of a very few. I want you to observe carefully in your own reading which substances actually do not have withdrawal symptoms. Okay? So for example, alcohol can be diagnosed with alcohol use disorder severe, alcohol intoxication, alcohol withdrawal. Okay, I showed this to show that there's a pattern and make it easier to make all sense of the diagnosis. There are diagnoses used to combine with the substances in the ICD. Notice that harmful use and dependence is combined in the diagnosis use disorder term in the DSM-5. So harmful use falls in the mild use disorder in DSM, and dependence can be either mild to severe use disorder. So in ICD, the diagnosis would be either alcohol intoxication or alcohol harmful use or alcohol dependence or alcohol withdrawal versus alcohol use disorder in DSM. Okay? So let us start with the diagnosis of substance use disorder. Use disorder is defined by the DSM as a problematic pattern of substance use. So insert alcohol here, for example. A problematic pattern of alcohol use leading to a clinically significant impairment or distress as manifested by at least two, so that's the symptomatic threshold, by at least two of the following. So a list of symptoms usually follows, occurring within a 12-month period. That's the temporal or time requirement. The severity specifier usually tells you how many symptoms are required for a use disorder to be either considered mild, moderate, or severe. So for example, in alcohol, 2 to 3 symptoms is mild, 3 to 5 symptoms is moderate, and then 6 or more symptoms is severe. Okay? So intoxication is diagnosed with the following criteria. Okay? Recent ingestion or use of alcohol, for example, clinically significant behavioral or psychological changes that develop during or shortly after alcohol ingestion. Okay? Ingestion of alcohol, like the criterion C would indicate, three of the following signs or symptoms developing during or shortly after. So we just review the symptoms. This is the pattern that I'm showing you. Okay, it differs slightly for each substance involved. Okay, and withdrawal by these criteria. So you just read this on your own. So let me bring back the list of substances in the DSM. We will take one prototype upper and one downer to discuss them more in detail. So take alcohol and stimulant related disorders. The prototype there is methamphetamine abuse. So let's first discuss our prototype downer or alcohol. Okay? So I guess the attraction of alcohol is that as the night goes on, your date becomes more and more appealing, eh? Pumupogi at gumaganda yung mga kadate. Alcohol is one of humanity's oldest psychoactive substances. In the Philippines, it's interwoven with celebration and social bonding, but also with accidents, violence, and health issues. This is Dionysius, the Greek god of wine, grape harvest, winemaking, ritual madness, religious ecstasy, and pieta. We will follow a biopsychosocial pattern in discussing the etiology, effects, and intervention related to alcohol use disorders. So biologically, alcohol exerts an overall depressant effect on the brain. Thus, we call it our prototype downer, as it is one of the most commonly psychoactive substances. We discussed earlier how these neurotransmitters are involved in the reward pathway. This slide shows you that alcohol use disorder has a genetic link. Pharmacologically, alcohol is mainly absorbed in the small intestine, but the alcohol absorbed in the stomach can reach the brain in 1 minute. So eating food, especially oily food, along with your alcohol slows this initial absorption. Remember, remember as well that the higher the proof of the alcohol, the faster it crosses the basement membrane due to its denaturing effect. This slide shows you that majority of alcohol is metabolized in the liver at an average of 1 drink per hour. We will discuss what 1 drink is equivalent later on. This slide shows you the effect of blood alcohol concentration as it increases. Again, study this slide. This is a must know, especially if you plan to work in the emergency room or in addiction medicine, as alcohol intoxication is very common. Let's move on to psychological etiological factors. Alcohol use is usually initially fueled by an unconscious desire to reduce anxiety and other mental health symptoms, commonly dysphoria or depressed mood. Individuals usually serendipitously discover that it boosts confidence and casts a veil over guilt. Psychodynamic theories also connect it with overgratification during a period in development, leading to either oral fixation or oral regression that happens when an individual who successfully skirt this stage encounter a tremendous stressor, leading them to regress to a more primitive stage of development. It can also be trained through modeling and direct reinforcement by peers or significant people you grow up. Okay? Social etiologic factors are the following. Okay? Avoidance of responsibility, availability of ready availability of the beverage, it's pervasive, right? Group or peer pressure, stressful lifestyle, and social attitudes to drinking. Okay? For example, it's usually difficult to escape the social influence reinforcing people to drink alcohol because this is what permeates in our social context. So yung mga advertisement taglines, di ba? Kahit kailan magkaibigan. Okay? Sarap ng samahan, implying unity. Okay? So how can we escape alcohol when we get haircuts from our community barbers and their calendars show this inspiring image, di ba? Very inspiring. For fairness, no one gets left behind. One for the girls or boys. Okay? Here's a summary of what we've discussed so far. Okay? Note that the genetic factors contribute 60% of the influence, while 40% comes from environmental factors. Okay? However, remember that later in the alcohol drinking, it shifts from genes to the pharmacologic effect of the alcohol molecules on the reward system, okay, as it becomes chronic use. So let's discuss alcohol before it becomes a problem. So here are drinking patterns. Which category do we fall in? Are we moderate drinkers? So let's define them. No? Moderate or safe drinking is defined as 2 drinks per day for biological men and 1 drink per day for biological women. Okay? What's a drink? Okay? A drink is defined as 1 can or bottle of beer. Huwag na tayo maging philosopher about the size of the bottle. Ha? Yung normal size bottle, hindi yung mucho. 1 glass of wine and 1 shot of liquor. So ito, visual cues for visual people. Okay, so para again sa mga pilosopo, 1 drink a day is moderate drinking daw for women and 1 glass of beer is only half a drink for men. But their glass and is this size. Heavy or high-risk drinking is defined in men as more than 14 drinks in a week or more than 4 drinks on any day in one sitting. And for women, more than 7 drinks in a week and more than 3 drinks on any day. This is the definition of binge drinking, a pattern of drinking that brings the blood alcohol concentration to 0.8 grams per cent or above. This is typically 5 or more drinks in biological men within a 2-hour period and 4 or more drinks for biological women. So it escalates into a problem. Heavy drinking is equal to harmful use diagnosis. On top are intervention that can be considered for each stage. What characterizes an addiction in general? There's usually a pattern, meaning it is happening in the long term, and DSM temporal requirements usually indicate within a 12-month period. There should be tolerance, meaning more and more of the substance, in this case alcohol, is needed to produce the sought after effect. There is dependence, meaning the brain is adjusted that it cannot function in the usual manner without the substance, and that they experience withdrawal symptoms when they suddenly stop using the substance abruptly. Review and familiarize yourself with the DSM-5 criteria for alcohol use disorder, alcohol intoxication, and alcohol withdrawal on your own reading, okay? As well as the DSM criteria for all the other substances. Okay? Let's talk about the biopsychosocial effects of alcohol use. Okay? Here are the biological effects of chronic alcohol use. The highest bar you see is from liver cirrhosis due to 90% of alcohol being metabolized in the liver. Okay, let's move on to psychological effects. Here are the common comorbid psychiatric disorders of alcohol use disorder. Most of these have bidirectional relationships with alcohol, meaning they are both risk factors for each other. So if we have depression, that increases the risk for alcohol use. If it started with alcohol use, it increases the risk for depression. So you're like chicken and egg. It makes things complicated. It makes treatment more complicated. Okay? Social. Here are the common social issues attached to alcohol use disorders. Tapal-tapal utang, vandalism, sexual misconduct, driving under the influence, and crime and violence. In an old study in the University of the Philippines, it was observed that Filipinos had an average age of commencement of drinking patterns at around age 16 to 17, with an earliest age of 12 years old. So recall when you first drank. when you first tried, and to which you ended up. Did you continue the habit? Are you using it occasionally, or you don't, or very seldom drink? Here are social factors that make a person more likely to drink. So, who among you lives in a dorm? Okay, so here's a summary of what we have just discussed about effects. So, now in terms of intervention, okay, here are some settings where you'll encounter individuals with alcohol use disorder. Note that we psychiatrists commonly receive referrals from inpatients of sudden changes in behavior, post-op or in the ward, and when we interview the relatives and patient, we discover that because they were suddenly hospitalized, they had to stop drinking, right? And it's now experiencing actually withdrawal symptoms. So we always have to take a proper history. Patient brought to the ER secondary to a motorcycle accident. Then you didn't catch that they were a habitual heavy drinker. So after a few days in the ward, the patient will suddenly have severe withdrawal symptoms. And you don't know where it's coming from because you didn't take substance use history. So you're the one who's going to be anxious about what's happening to your patient. History, history, history. Okay? The question is, do we have local protocols and guidelines in place? The answer is no. Some institutions have detox protocols, but there is no national guideline published. Usually use foreign recommendations from the US, UK, or Australia. What are biological interventions we can implement? Okay? At home, we can detox by hydrating profusely, as alcohol is easily flushed out by fluids. Take oral vitamin B, multivitamins, rest, and eat a lot. At the ER, it is important to take a thorough history and physical exam. Collateral informants can help a lot in this regard. We have to hydrate with non-glucose containing fluids. If you want to use glucose containing fluids, we have to initially give thiamine, as it is a coenzyme in glycolysis, and flooding the system with glucose will shift the cycle into producing a lot of lactic acid, causing lactic acidosis instead of ATP. So provide oral thiamine or incorporate it with the IVF if you're using plain NSS. And test and correct for electrolyte imbalances. They are very common in intoxicated individuals. Lalo na if they were vomiting after they drank a lot, they vomit, so they have electrolyte imbalance aside from all the other reasons why. Okay? Patients with withdrawal symptoms are ideally admitted in the ICU for close monitoring. Apart from the steps earlier, we can give benzodiazepines as they will substitute for the alcohol molecules in occupying your GABA receptors and prevent delirium tremens. They are problematic seizures caused by alcohol. If your patient is experiencing agitation or psychotic symptoms, you can start low-dose potent antipsychotics. Okay? Note that some antipsychotics can actually lower the seizure threshold. So you just have to know the pharmacology of your medications properly. Okay. Here are some medications available locally that can be used in alcohol use disorder. Please read other medications that are not necessarily available but are nice to know. Okay, so we have this here in the Philippines: naltrexone, gabapentin. Disulfiram we don't have. Okay. For psychosocial interventions, I've shown you this slide earlier on what kind of psychosocial intervention can be done for each stage of alcohol use disorder. Here are some effective behavioral therapies for alcohol use disorder. Okay? And here's a summary of the interventions that we have discussed. So in summary, right, for alcohol, this is a summary slide for you. Study. Okay. As you know, methamphetamine is the most prevalent stimulant abused in the Philippines. Yan ang pang iba, tinatawag banga. Diba? Here is a summary of historical aspects of methamphetamine. Okay? Biological. Methamphetamine is a monoamine releaser, as we have discussed before when we were discussing the reward pathway. Stimulants reverses the reuptake transporters and floods the synaptic cleft at the nucleus accumbens of dopamine. It also interestingly inhibits monoamine oxidase, the enzyme that breaks down dopamine, causing dopamine to linger. So ni-flood na niya, it also inhibited pa the enzyme that metabolizes dopamine. The net effect is heightened arousal, decreased fatigue, euphoria, followed by a crash, by a crash upon dopamine depletion. Pagod na si Dr. Alipio. Here are some important pharmacokinetic properties of methamphetamine. There's no way to go about this. These are all must knows. Okay, so study this. Here is a summary of what happens pharmacokinetically when an individual takes a stimulant. There is an initial rush, an extended high, then a crash, and a hangover if they don't take a maintenance dose. Maintenance dose talaga yung tawag ko. Okay? For psychological predisposing factors, gateway substances often increase the risk for later meth use. Comorbid psychiatric disorders, especially those that involve depressed mood, often discover that taking stimulants improve their feeling and start to abuse them. A similar mechanism happens to individuals with ADHD. They serendipitously discover taking meth calms them down, so making them focus, so it becomes their Ritalin. So if you remember, Ritalin is also a stimulant, okay? Because it's complicated of like why dopamine stimulants are the treatment of choice for ADHD. It's a discussion for another topic, okay? But it's interesting. You could read on it on your own. For now, anxiety. Individuals with anxiety and with certain character neurosis or individuals with history of trauma can also have higher risk for developing meth use disorder. Okay? Here are social predisposing factors for meth use. Accessibility, peer pressure, for example, security guards, bus drivers, all right? Certain kind of family environments, community factors, okay, stigma and some twisted cultural narratives as indicated. So what does meth do to people? Biologically, meth causes hyperactivity, insomnia, and appetite loss. Chronically, it could lead to neurotoxicity, meth mouth, weight loss, and increased risk for stroke. Psychologically, it triggers paranoia, hallucinations, aggression, and deep depression after the high. Socially, meth destroys families, increases violence, and fuels the criminal justice burden. Right? What are our interventions? Here are abuse patterns for meth use. Okay? Acute management uses benzodiazepines for agitation, antipsychotics for psychosis, and aggressive cooling for hyperthermia. Withdrawal care is supportive, rest, nutrition, and monitoring for suicide risk. No specific pharmacologic cure exists yet. The trials using bupropion, mirtazapine, and naltrexone show promise. You'll remember naltrexone, okay, because it acts on the reward system. Eh. So it's not only, well, it's technically all indicated for alcohol, but you could use it off-label for all the other use disorders, including behavioral disorders. Okay? Psychologically, cognitive behavioral therapy, contingency management, and motivational interviewing are most effective. Socially, therapeutic communities and family involvement remain the mainstays of long-term rehabilitation in the Philippines. The most common form of rehabilitation program is called TC, or therapeutic community. It's a topic in itself, all right? There's like specific guidelines on how it is implemented, right? Addiction is a chronic brain disease that involves reward, stress, and control circuits. Alcohol represents the classic downer, enhancing inhibition. Methamphetamine represents the classic upper, overstimulating the brain. Treatment must always be psychosocial, addressing the brain, the mind, and the environment together. So thank you for listening. Please review the DSM-5 diagnostic criteria, the reward pathway diagrams, and my summary tables, which I will show you in the following slides. Reflect on how these mechanisms explain real clinical behavior, from craving to relapse. And remember, compassion and science must always go hand in hand in treating addiction. So we'll go over the slides real quick, okay? So here I have summarized all the substance use groups, all right, and their common, what are common examples in the Philippines, their mechanism of action, right, molecular mechanisms of action, and some remarks that are must knows about them. Okay, alcohol, caffeine, cannabis, hallucinogen. The most All right. There are different kinds of hallucinogens, but shrooms are not that common here in our country. What we observe usually at the ER is either accidental or intentional use of kalampunay. It's the angel's trumpet, okay, or kalampunay. It's actually not a classic psychedelic. It's a delirium. Pero yan yung, but it's also hallucinogen, okay? Very common in the ER. Okay, the most common inhalant would be rugby. Okay, rugby boys. You see them on the street, and we have morphine, codeine, and tramadol. All right, I jumped pala forward. So alam niyo naman yung mga iba. So cannabis, cannabis. Okay, so our common sedative hypnotic abuse would be benzo. All right, and then for stimulants we have shabu, cocaine. Not really rare, but like it's actually common now. But it's compared to shabu, cocaine is much lesser. We have ecstasy or MDMA, and then we have that songs. Okay, this is common in the United States. That's why I included it. Then tobacco. Okay. So after that, I have provided you with more details for each of the groups. So for example, this resummarizes alcohol pharmacodynamics, pharmacokinetics, some notes on intoxication, management, withdrawal. Okay. Okay. So it follows that pattern for each of the substances that are under the DSM. Okay. So this will be provided for you on the slide. So that's it. Thank you very much again and enjoy reading.